Have you ever felt like you're trying to memorize an entire dictionary of bone, joint, and muscle terms? It's a huge topic, I know. But today, we're going to make it simple. Welcome back to the PTCB Prep Guide. In this explainer, we are breaking down all the essential musculoskeletal disorders and, most importantly, connecting them to the exact medications you need to know so you can walk into that exam with total confidence. Let's get right into it. Oh yeah, I know that feeling. You're just staring at these long, complicated lists of drugs and conditions, and after a while, they all just kind of blur together, right? Well, we're not doing that today. Instead of just memorizing, we're going to actually connect the dots. By the end of this, these ideas are going to be clear, simple, and they'll actually make sense. So here's our game plan. First, we're going to tackle what I call the intruders. Those are the infections and inflammatory conditions that attack our bones and joints. Then we'll shift gears to building stronger bones. After that, we'll dive into how to manage those sudden injuries and muscle problems. And to finish it all off, we'll lock it all in with a rapid review to make sure you are absolutely exam ready. All right, first up, the bone and joint intruders. These are the conditions that can cause some really serious issues, so let's break them down. Let's kick things off with osteomyelitis. Now, I want you to picture an infection that gets deep, deep inside the bone itself. This thing is incredibly stubborn. You know why? Because blood flow inside our bones is pretty limited, which makes it super hard for the body's defenses and our drugs to even get to the problem. That's why we need very specific, very powerful antibiotics to wipe it out. This is a must-know. So, how in the world do we fight an infection like that? Well, we bring out the heavy hitters. You can see drugs like cefazolin are a common choice, but the one you really need to circle here is vancomycin. Vanc is our go-to for fighting those really tough, resistant bacteria like MRSA, which, you guessed it, is a frequent cause of these serious bone infections. Okay, this next one is a huge point you have to nail down: the difference between osteoarthritis and rheumatoid arthritis. The easiest way to think about it is this. Osteoarthritis is just wear and tear, kind of like the tread on your car's tires wearing out over many years. But rheumatoid arthritis, or RA, is a whole different ballgame. That's an autoimmune disease where the body's own immune system gets confused and literally starts attacking the joints. So because the causes are worlds apart, the treatments are too. And you can see that difference perfectly right here. For that wear and tear osteoarthritis, we're often starting with something simple, like an NSAID, ibuprofen. But for RA, we have to deal with the immune system itself. And that's where you see these powerful drugs come into play, like corticosteroids or DMARDs. That stands for disease-modifying anti-rheumatic drugs, like methotrexate, and even biologics, like Humira. All right, next up is gout. Let's make this super simple. Just picture tiny, sharp, needle-like crystals made of uric acid building up in a joint, usually the big toe. That's it. It's those little crystals that cause that sudden, excruciating pain. And if you can remember, it's all about the crystals. The medications are going to make perfect sense. So this is a classic exam question. What's the goal of the treatment? If a patient is having a painful, acute attack right now, we use colchicine to calm everything down. But for long-term prevention, to stop those crystals from even forming in the first place, the #1 drug is allopurinol. Knowing the difference between acute and chronic here is absolutely everything. All right, we've talked about the intruders that attack the joints. Now let's shift over to a structural problem. What happens when the bones themselves start to get weak? And that brings us to osteoporosis, which is often called a silent disease. It's a condition where bones become less dense and more porous, almost like a honeycomb inside. This makes them so incredibly fragile that they can break from just a minor fall, or in really severe cases, even from a strong sneeze. It's a massive health concern, especially for postmenopausal women. So, what are our strategies to fight back? Well, here are the main classes. Our frontline therapy is a class called bisphosphonates. A great example is alendronate, brand name Fosamax. Basically, they work by slowing down the cells that break down bone. We also have other options, of course, like SERMs, that's selective estrogen receptor modulators, and different kinds of hormone therapies. Okay, I need you to pay close attention here because this is a huge PTCB pearl. The counseling points for bisphosphonates, like Fosamax, are so important and they are highly testable. You've got to remember these 3 steps. Take it with a full glass of plain water, nothing else. The patient has to stay sitting up or standing for at least 30 minutes, and no other food, drink, or meds during that half hour. Now, why? Because these drugs can cause serious damage to the esophagus if they get stuck. Remembering why you're doing it makes the rules totally unforgettable. Okay, let's totally shift gears. We've covered chronic conditions. But now, let's talk about the acute stuff. What happens when there's a sudden injury, and how do we manage the pain and muscle issues that come with it? Strain versus sprain. People mix these up all the time, but here is a foolproof way to remember it for the exam. A strain involves a tendon or a muscle. See, the T is your clue. A sprain, on the other hand, involves ligaments. That simple little memory trick is gold. And that leads us right into muscle spasms. We've all had one, right? That sudden, tight, painful knot in a muscle that just refuses to let go. It's an involuntary contraction. And to treat it, we need a special class of drugs designed to basically tell that muscle to relax. And here they are, the muscle relaxants. For your exam, you absolutely need to know names like cyclopenzaprine, brand name Flexeril, and carisoprodol, which is Soma. A really key point here is that these are typically used for short-term relief of spasms that come from a sudden injury. Of course, with any injury, we also have to manage the pain. I want you to think of it like a ladder. For milder pain, especially if there's swelling, we start on the lower rungs with NSAIDs. If there's pain but no inflammation, we can use acetaminophen. But for severe pain, like from a broken bone, we have to climb that ladder to the top rung, the opioid analgesics, like morphine or oxycodone. Okay, you've taken in a ton of information. Let's lock it all in. It's time for a rapid review to test those key connections we just made. You ready? First question for you. Think back to building better bones. What is that go-to medication class for preventing fractures in osteoporosis? If you said bisphosphonates, you got it, with alendronate, brand name Fosamax, being that classic example. And please, never, ever forget those critical counseling points. Stay upright. Question 2. A patient is having a painful, acute gout attack. They need relief right now. What's the drug we're reaching for? Not for prevention, but for the attack itself. That's it. Colchicine, brand name Culcris. Remember the two different jobs on our table. Colchicine for the acute attack, allopurinol for chronic prevention. Nailing that difference is a guaranteed point. And for our final question, what is that one fundamental difference between RA and OA? It's that core concept, right? Osteoarthritis is wear and tear, but rheumatoid arthritis is an autoimmune disease where the body is attacking itself. That single distinction explains everything about why the treatments are so wildly different. And that wraps up our musculoskeletal essentials. If today's explainer helped you connect these dots a little easier, make sure to subscribe to the PTCB Prep Guide for more streamlined learning every week. Stay committed, stay confident, and I'll see you in the next one.